This is our 74th Innovation Brown Bag series, and I'm going to keep it short, and for that reason, I wrote it down. So it says, welcome to the Innovation Brown Bag. Today, we actually have a very interesting healthcare topic and a healthcare speaker. So healthcare is all about improving patient outcomes, and one way to improve patient outcomes is through patient engagement and advocacy. And some of us actually have experience with both of those dimensions and the challenges associated with that. And today we are truly honored, and I'd like to actually make sure to thank Nahum for arranging this and making this possible. But we are truly honored to have with us a speaker who's really been on the vanguard of patient engagement through personal experience and otherwise, and I'm sure you'll hear the details. So those of you that are in the Twitter sphere may actually know ePatient Dave, or Dave deBronkart. And he's a frequent speaker, obviously, joining us today, both nationally, and engages in the national discussion on healthcare policy and practice. So also authored several books. Most recent book from 2003, Let Patients Help, a Patient Engagement Handbook. Please join me in welcoming ePatient Dave.
Thank you, and thank you, Jonathan. For those of you who remember Jonathan Livingston Seagull, I'm revealing my age. In fact, I turned 65 this year. This is not what, I know, single payer for the world, right? It's amazing. The world is changing. The world of healthcare is changing in ways that are not obvious until you dig into how much the infrastructure of information flow affects what happens in healthcare. And it's my fervent hope, from what Nahum has told me that you folks are up to with CMS, that what I might call radically different thinking will alter how things work out for the party that I call the ultimate stakeholder, which is the patients, the people whose lives, whose families' lives are on the line. Time after time after time, as my own speaking career has grown, I've gotten invitations to attend or speak at some marvelous global summit of blah, 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 involving all stakeholders. And all stakeholders includes doctors groups, hospital groups, insurance companies, vendors, no patients. And this is a dysfunction born of the way that we pay for healthcare. And I will make the case for you here today that there are things that are, number one, understandable to you as consumers of healthcare, and ideally things that will alter or reinforce your approach to how we transform what happens when somebody finds themselves in trouble, or when they just want to maintain things. This is the first time I've ever used the term war in the title of a talk. A culture war begins. I will say that before I discovered I was almost dead in 2007, I had worked in marketing my whole life, so I understand the value of having a good brand. And so after my cancer, I started a blog called The New Life of Patient Dave, because I hadn't died. Then when I discovered the ePatient movement, which I'll explain, I just changed it to The New Life of ePatient Dave. And when Twitter came along, I said, that's it, that's who I'll be. On Facebook, I'm ePatient Dave. I'm LinkedIn, ePatient Dave. My website is epatientdave.com. It's the value of a consistent brand, okay? And if you were going to ask about my Skype ID, you should understand there's this thing of internal consistency, right? Anyway, all of this I'll explain a bit more. I'm talking about a culture war because it's become clear to me in the last year that it is time for a real shift in our paradigm, and I don't mean that in the airheaded, trendy buzzword way. I mean really rigorously Thomas Kuhn's structure of scientific revolutions, rethinking what is this thing in our cognitive world that we think of as patients. And I will be talking to you both as patients yourselves and as beneficiaries of care, because my story shows, my wife's story shows, and a college friend, Doug White, who works at Lincoln Lab, is here. And a few years ago, because of my story, he told one of our dorm friends who had lung cancer that was going the wrong direction about this. And long story short, a year later, she had no evidence of disease because of information she found through this new information infrastructure. It is not easy for most people in medicine to understand. And I'm not insulting physicians, far from it. I was saved by great physicians. I'm saying that you people are all here because you're wicked smart, right? That's the only way you get to work here. And so think deep. How I came to be here. I worked in high-tech marketing my whole life. I'm an MIT graduate, 1972, and I ended up working in the typesetting industry, of all unlikely things, based on my experience setting type for the school paper. That's a whole separate story. Don't listen to anything he tells you about what I did in college. I'm a data geek. I do unnatural acts with Excel. I'm proud of it. I follow tech trends. Disruptive innovation. People talk about disruptive innovation. It's another airheaded buzzword. But I'm here to tell you, you want to talk about an industry that went through change when typesetting machines were confronted, and that was a noble profession, when they were confronted with desktop publishing, where ordinary people who had none of the journeyman experience of understanding kerning and proper font selection, the great unwashed got their hands on fonts. And we said things like, no, you can't handle the Helvetica. You don't know what you're doing. Well, this is exactly what's happening now in medicine, where people with really good training are saying, no, you don't understand that. It's more nuanced than that. And yet, the trend of history is obvious. We all have fonts on our computers, and most of us have fonts on our phones these days. And over time, people have gotten more of a clue about how to use them reasonably. Applications have been retuned. And importantly, the applications have become more focused on what's of value to the end user. And this is the direction that things are heading in healthcare. I also love automation. One important thing, by the way, my most obscure claim to fame is that I wrote in QuickBasic, if you can believe that, the world's fastest software for typesetting business cards. Now that's a niche market. But in the 90s, in the era of mergers and acquisitions, when one bank bought another one and all of a sudden 14,000 people need new letterhead, and that was before email, right? And business cards and everything, it was really valuable to have automation. But we learned that the data quality is essential because otherwise you're going to get high-speed garbage coming out of the printing press. And a major thing to be aware of here, not just for your own benefit, but because it reveals something profound about how medicine has been practiced. The Wall Street Journal had a front page story on their health section last June, a year ago, saying that over 80% of people's medical records contain a fact, an error of some substance. And the reality is that there are no data quality filters on information getting into the medical record. So as people talk about big data analysis, well, big data analysis of crap is not going to be very useful. How would you I asked one of the Watson people at an event in Washington last month, how would you alter Jeopardy Watson? It can read gazillions of pages a minute, right? How would you alter it if you had to tell it that 20% of what it read was wrong? Well, that's the reality that we're facing here, because for the most part, medicine doesn't understand information theory. 2007, I discovered I was almost dead and recovered in less than a year. I'll tell that story. I'm not kidding. It's not exaggerated. 2008, I discovered the e-patient movement and started blogging about it as a hobby. And in 2009, I wrote a blog post. Anybody remember Google Health? It was this thing where Google would say, give us your data and we'll take care of it for you. Well, my hospital, Beth Israel Deaconess, was the first one in the country, first one in the world to offer a button, say, move my data to Google Health. I poked that button, not because I trusted Google, but because I wanted to seed innovation. What came across was crap. things I'd never had, everything I'd ever had. I mean, acne was listed as a current condition. And things I'd never had and all kinds of, so it took me a month because I'm not a food fight blogger. This is another social media aspect of this, access to power. It took me a month to figure out what I was gonna say about this, because the easiest thing in the world would have been to say, haha, Google sucks, you know, throw another bomb at Google. And what I ended up writing about was, do you know what's in your medical record? You know, because that's a question that could make a difference in the future of things. 3 days later, it was a 3,500 word blog post with screen grabs and all kinds of, it was more like a feature article. 3 days later, the Globe called and said, we think this is important, could we write about it? I was like, what? Well, what I didn't realize was that the federal stimulus bill had just been passed with billions, tens of billions of dollars to incent the adoption of electronic medical record systems. And there was a policy fight going on in Washington right at that moment on how to populate these new systems with people's history, because all the data out there is in doctors' handwritten notes or just open text, unstructured text. And some genius had decided that what we ought to do is upload people's insurance billing history, which, sad reality, is crap. It's inflated for higher billing purposes. You have horrible kinds of modeling error where stuff gets encoded one way just so it fits in the insurance system when it's not true, and things. And my blog post, it turns out, destroyed that thing. They not only wrote about it, they put it on page 1 on April 13th, 2009. My life started spinning out of control. Like, people have said if this was a Disney movie, everyone would say this only happens in Disney movies. So, I mean, so here's the cancer survivor blogging in his living room, right? And all of a sudden, page 1 of the Boston Globe comes spinning out of the screen. And that was a week before our conference where people were stopping me in the hall saying, I can't believe you're that guy. And a month later, I was testifying in Washington. True story. I mean, when I actually testified a year later at one of the policy meetings, there I am in front of this horseshoe-shaped table of microphones. And I said, it's in the transcript, I feel a little bit like Reese Witherspoon in Legally Blonde, you know? I don't have a chihuahua in my pocket, but I'm not sure how I got here. Well, anyway, that same year, 2009, some colleagues formed the Society for Participatory Medicine. I'll get back to that. And people started asking me to give speeches. And crazy. In 2010, I felt a calling. Honestly, I did. I am not a woo-woo la-la sort of person, but this is the first time in my life I felt that I had a reason why I was here and something I had to go do. And having worked in marketing all my life, I had learned long ago how to give a speech that connects with an individual audience. So I jumped off the cliff without a business plan. It took me 3 solid years to reach break even, get caught up on my taxes and so on. But late in 2012, Ginny and I, my wife and I, were able to just take 2 weeks vacation and go visit, stay with friends overseas. Anyway, in 2011, started going international. I did my TED Talk, and here we are. Now, being a marketing guy, I like aphorisms. I like to take complex subjects and boil them down into slogans. So we have, for instance, the doctors who formed our society named it the Society for Participatory Medicine, 14 syllables, right? My book is titled, Let Patients Help, right? Here's one. People perform better when they're informed better. This is more important than you might think. It's so freaking obvious. And yet, the tradition is to say, don't give patients that information. They won't understand it, which tends to be self-perpetuating. All right? So one of the big movements that's going on these days is data liberation. Todd Park was the chief technical officer at HHS a few years ago, and that was his mantra. And the empire is starting to strike back, as we'll see later on. People saying, no, back off, that's my stuff. Here's a corollary. It's perverse to keep people in the dark and then call them ignorant. But that is what's happening. Next aphorism, really important. Patient is not a third-person word, okay? Your time will come. The first health policy thing I ever attended at the Hyatt Regency in Cambridge, spring of 2008, I noticed that everybody was talking about patients as if it was people out there on Memorial Drive. Well, I had recent experience that all this talk about healthcare looks really different when it's your ass on the line or your mother's or your kids or whatever. So what I've come to saying is, trust me, the time will come where it affects life at your breakfast table. So when you hear my story, think about this in terms of personal impact. Most of the people in the healthcare professions, as good as they are at what they do, think of it as those other people out there. Warner Slack is one of the senior physicians at my hospital, Beth Israel Deaconess, and a longtime mentor of my primary physician. He's been saying since the 1970s that patients are the most neglected or underused resource in healthcare worldwide. Now, this begs a really big question. Given that it's hard to become licensed as an MD or to become a PhD researcher developing cancer treatments and so on, what the heck is he talking about? What is it in concrete? Some people talk about patient engagement and patient empowerment like, ooh, kumbaya, woo la la, think lovely thoughts and healthcare will get better. I have an engineer brain. I never got anything beyond a bachelor's degree, but I understand the scientific method well enough. I want to understand what's the mechanism, what's happening here. We'll get into that. Well, good heavens, the picture of Tom Ferguson has disappeared. Well, he was the founder of ePatients.net. He was a post-Woodstock doctor who came out of Yale Medical School, and he was a visionary. He was really, my definition of a visionary is somebody who correctly sees at least 20 years in advance what's going to happen. He saw that the vast majority of what we do medically is take care of ourselves and our family at home, but he also saw that when trouble hits, access to information makes a huge difference in how much we can contribute. Trouble like stage 4 kidney cancer, like I had. And when the internet came along, and I say internet before the web, when the internet came along and became more open to the public, and then the Mozilla browser, he saw that this would alter what was possible. Not what would happen for sure, but what was possible. All right? And he started, across the top of this slide here is this lovely picture of 12 of his disciples, one of whom is my primary physician, but they've gone somewhere else for now. But he started spotting people who were doing what he talked about. The first one was a man named Gilles Friedman, who today runs a company called Smart Patients. He started a network of listservs in the early 90s of cancer patients, which I eventually joined. There was also my primary physician who wrote the first paper, a peer-reviewed paper on how to do doctor-patient email. That was published in 1998. If your physician will not do email with you, there may be a certain lag time that you might want to discuss. And he coined this, culture change, the dissemination of new practices. He said, e-patients, equipped, engaged, empowered, enabled. As I said earlier, in 2009, that gang of crazies decided the time had come to form a society, stop being a hobby club. So this is my primary physician, Dr. Danny Sanz at Beth Israel, and me. This is how he holds the computer. You want to look for the triangle configuration. EMRs in general these days, the usability sucks catastrophically. People having to do an absurd amount of clicks to get something simple done. It's common for mistakes to get in, and both patients and clinicians are complaining about the doctor's nose, the nurse's nose is in the computer. Do it like this. It's not uncommon for him to make a mistake, left hand, right hand, and so on. One of my x-ray reports from before my cancer identified me as a 53-year-old woman. You'd think that with a male name, I don't know what they saw. Anyway, notice that this society's emblem is a handshake. This is not about patients overthrowing the establishment. This is patients as partners sharing the work. All right, and it turns out that this is more feasible than it was 20, 30 years ago because of all this. Much to my amazement, they said this society can't be run by just a doctor like most medical societies. It has to be a doctor and a patient. And they elected my doctor and me as co-chairs. So I went from being almost dead in 2007 to chairman of a medical society in 2009. Students of martial arts have said this is like jujitsu, where you use the energy of the attacker to propel yourself forward. Well, Health Leaders magazine goes to tens of thousands of hospital executives. They got wind of this, and they came and talked to a bunch of us, and to our amazement, they made it a cover story. They called it The Patient of the Future. Now, I am very interested in the history of culture change. As a child of the 60s, I watched a whole lot of culture change, race relations, feminism, and so on. So when things start showing up in new places, I'm very attuned to that. And of course, in a sense, that's analogous to marketing, where you take responsibility for what people are hearing when you talk about something. If we had gotten a $50,000 founding grant from the Robert Wood Johnson Foundation, and we'd hired a PR firm, and this had happened, we would have said, dude, most excellent, you got us a cover story. But we didn't. This was the editors of Health Leaders, and they got it right here. It's about this new relationship. It's not about what patients are doing differently, it's about this relationship. They sent a photographer to my house and to other people's to take pictures. I thought it was just going to be the head, cut into a column of type. Quite honestly, I would have worn a different shirt if I'd known they were going to do this. Full page on the table of contents. Now, but this is kind of the point. They're saying the patient of the future is a middle-aged schlump in a tacky shirt looking stuff up on the internet. All right, and this is the reality. I mean, the Pew Internet and American Life Project research says that the great majority of us routinely look up a symptom or two now and then. And there are people who say, stop Googling, you don't know what you're doing. Well, we'll get to that. Every year they run 20 people who make healthcare better. And this particular year, number one was Atul Gawande, who is this extraordinary surgeon and author. He writes terrific books. They're complex subjects. They go down as smooth as tap water, writes essays for the New Yorker. It's very obvious that he's improving healthcare. Number two is Dean Kamen, best known as the inventor of the Segway, not so well known as the inventor of the wearable insulin pump in 1976, so that people with diabetes could wear a backpack insulin pump and go out. This time he was honored for the robotic limbs his company's making for amputees, like a smart knee that knows when the ground is wobbly. Imagine my shock when number 3 on the list was me in that stupid shirt. It's like, guys, it's obvious I didn't have a PR firm, right? But importantly, number 4 was Dr. Sanz, my primary physician. And what the editors of Health Leaders magazine were saying to their audience is that this patient participatory relationship belonged on the same page with Atul Gawande and Dean Kamen. So it was at this point, this was December of 2009, that I just started feeling like something's happening here. So I asked myself, obviously the 128 area, Silicon Valley, are full of people who had what they thought was a great idea and they just flamed out immediately. So I asked myself, am I really an indicator of the future? So I looked for evidence. Is there any evidence in my previous half century of this? Well, I thought, who's getting online? Well, I've been on CompuServe since 1989. Back when you needed a modem on your phone line and all that stuff, and I was a sysop of several forums. 20 years later, Pew Internet and American Life Project said 76% of US adults were online. So by that one measure, what this monopoly piece was doing in life was a predictor. But that's just one data point. I looked for more. I looked around and I thought, well, how about romancing online? Well, I found my wife on the internet, on Match.com in 1999. Now, people say, and by the way, I mentioned I'm a data geek and in marketing. Well, a year later, I got invited to give a speech about XML in Paris. So we got hitched and made a honeymoon in Paris out of it. There she is on top of the Musée d'Orsay. This was not bad. 10 years later, 1 in 8 US weddings was people who met online. What's possible for people to find what they're looking for has changed because of the infrastructure change created by the internet. I'd been involved in a distance relationship with a woman in Florida. Ginny was 13 miles away from me. I was like, dude, I'm going on a date in a car. I'm not kidding. It was like information latency. You know, the information was there, but we weren't aware of it. Well, now some people have said, you know, patients, stay off the internet. There's garbage out there. Well, I assure you, before I found Ginny, I went through some suboptimal search results. And if you've ever been on eHarmony or anything like that, you might know what I mean. Well, and in 2011, 1 in 5 couples was people who met online. And if you think about people in our generation, that may not seem so obvious. If you think about my daughter's generation, So I want to get into my case, a short version of my case. I was an engaged patient long before I knew the term existed. To me, it was just like being a responsible shopper for cars or TVs or whatever, just learn what I can. You know, I don't claim to be a car mechanic or a TV engineer, but just learn what I can. So I had moved away. Dr. Sanz had been my primary since 2002, 2003, I think. I had moved to the Midwest for a few years, and I was coming back in 2006, and I wrote to him and said, will you take me back? And he said yes. And because we hadn't seen each other for a while, I had a lot of things I wanted to talk about. And instead of waiting until I got there to haul out my list, I emailed it to him in advance. Some people say, you emailed your doctor? Well, we have this relationship, and he said he's glad I did, because he had things he wanted to go over. If you go see an accountant or a lawyer or something, do you wait until you get there to say why you want to meet? And yet in medicine, we have this culture of I'm going up the mountain to see the guru, and certainly wouldn't want to bother them with information in advance. Well, anyway, here's how this worked out, okay? One particular item. A month before the appointment, I had an odd thing start happening in my right eye, okay? And it was kind of a blurry, sparkly thing, and it got bigger and bigger. I tried to wipe it away, it didn't go. There was nothing in my eye. And in a half an hour, it eventually got big enough that I could see it was crescent-shaped. And when I do this to audiences, to doctor audiences, you can see they're doing their differential diagnosis thing. Could be this, could be this. Well, it's reasonable. And that in a half an hour, it had outgrown the eye and was gone. And the first time it happened, I thought, whoa, flashback. I am a child of the 60s, as I said. The second time it happened, be quiet. This is the second time it happened, I thought, what was that? Because it was exactly the same. And the third time it happened, I started taking notes. I'm no doctor, but I know how to keep a science notebook, right? And what I did, instead of waiting until we got there, until I got to the visit, is I went out and Googled my butt off for like 2 hours. And I said, no, it's not like this, it's not like this. This is what it's like. And I pasted it into the email. All right? That's what the symptom looked like, except it didn't have the triangle lines. I pasted in the URL, same as you would with a colleague. I found this, what do you think? I pasted in my little diary. People say patients shouldn't diagnose themselves on the internet. Who am I to diagnose myself? But this was a page about ophthalmic migraine, so I pasted that in with a question mark. The essential thing here, as an engaged patient, I wasn't trying to be the doctor. And this is important because you'll see headlines, patients play doctor, patients play researcher. I wasn't trying to be the doctor. I was trying to do everything I could to be an effective partner with my chosen expert. That's what an e-patient does. Well, as it happens, we got this resolved before I even got there. Now, another thing was I had a stiff shoulder. It wasn't really painful, but it just did not move well. And I said, I'm probably going to need a referral to a specialist, so please make that appointment in advance. Because from my father's final illness, I'd remembered cases of referral to the next person. It's like 3 months at a time, and this is ridiculous. This will not happen anymore when medicine is transformed to be oriented around patient needs. Places like the Cleveland Clinic, you can get a same-day referral into any specialty. If you're there for one thing, you can see an orthopedist or whatever you need the same day. So this is, anyway, I said, defensively, I said, get me an appointment, we can cancel it if we need to. Well, this is the point where the story is frozen in multi-sensory recall. And if you've ever had anything like this happen to you, you'll know what I mean. So I had that physical on December 30th, 2006. On January 2nd, I went to the orthopedist, one of the Red Sox team physicians on Beacon Street. The next morning, a few blocks from here, I guess, no, it was in the office on 128. I remember 9 a.m. exactly. I remember what my desk surface looked like. I remember what the blue carpet on the cubicle partitions looked like. I remember the Sony desk phone saying 9:00. I don't know what the mechanism is by which the brain does this total recall of moments where your life changes, but I can just bring that right back. The phone rings and it's Dr. Sanz, and he says, Dave, the radiologist called me, and he said, I called up the screen, the image on my screen at home, and I'm thinking, can I call up the image on my screen? Well, we're starting to get there. I have all my radiology images in my Mac now with the Osirix open source radiology viewer. So we took my wife to the emergency room because of a foot problem, had her images in there. Anyway, he said, your shoulder's gonna be fine, but there's something in your lung that shouldn't be there. And that shadow, he said, we don't know if it's a fungal thing or a scar from some old infection, but we need to find out. And to make a long story short, I went in for my first of many CAT scans. And here's what we found. This was a golf ball-sized tumor in the other lung. Turns out there were 5 of these in both lungs. So now we knew it wasn't anything else. It was cancer. Lung cancer doesn't look like this, so it means it was some other cancer that had metastasized. It had spread. And by definition, that means it's stage 4. It raised the question, where's this from? Which conveniently enough abbreviates to WTF, which is pretty much how I felt about it. And so we went in. Ginny is a veterinarian. I had to go in for an abdominal ultrasound, and she knows I'm not a dog, but she's seen lots of mammal ultrasounds. And it turned out to be the kidney, where there was this mass. They didn't confirm the diagnosis until they'd done a biopsy and looked at it and said, yep, this is renal cell carcinoma. But we pretty well knew what was going on. I went home. Some people say, patients, stay off the internet, you'll scare me. It's fine with me if somebody doesn't want to know. There's this concept in medicine these days, patient-centered care. If somebody wants to say, I don't want to know anything, just fix me, that's fine with me. There were days when I felt that way during my treatment. But if somebody wants to know more, the nurse practitioner who ran my case said she knew from the very beginning. She had just come from pediatric oncology. She had to be able to read her patients' moods and preferences without them being articulated. She said, you got a big appetite for information. So, WebMD. The prognosis for any treated patient with progressing disease, progressing is metastasized, is poor. Almost all patients are incurable. I've always known, if you don't like the first page of search results, keep looking. Well, and I did, and every single article to the 3rd page of Google said things like, outlook is bleak, prognosis is grim. And I didn't even feel sick. I mean, I was getting tired in the evening, but I was 56. What the heck? I'd been slowly losing weight, but to me, that was a victory. Doctor had been telling me to lose weight, right? My appetite had been shrinking, which I figured was why I was losing weight. I was finally becoming less hyper. In the end, all those things counted against me. Here's a diagram of stage 4 kidney cancer from the website of the drug that I eventually got, high-dose interleukin-2. Totally by coincidence, there's that thing in my lung. Oh, come on, is this gonna not? There we go. All right, anyway, there's that thing in my lung. I'm a poster child. The left leg, the left femur, my first pain was 6 weeks later when my leg started hurting. I thought it was a knee problem. It turns out I had a big bone metastasis. In May of that year, I fainted in the bathroom and landed on it and snapped, so I have a nice steel femur now The bone has grown around it. If you look at the head, that shows a brain metastasis. Mine was actually in the cranium. I have a moth-eaten area at the back of my skull. And being an MIT overachiever, of course, I have extra ones everywhere, including if you look at the head again, just before treatment started, I had one erupt from my tongue. I had a kidney cancer tumor growing out of my tongue muscle in my mouth. Only the most aggressive tumors grow in muscle tissue, they tell me. By the time I found a website that could score the disease, they made a point of saying there is not good information for your case, just not enough good evidence. But I wanted to know what I could, and what I found by the time I added up all those things, 24 weeks was my median survival at diagnosis. Ladies and gentlemen, this will focus the mind. I knew enough about statistics to know that the median isn't the middle, isn't the guarantee. I know Stephen Jay Gould's article, median isn't the message. But I woke up at 1 o'clock that morning. I remember vividly looking at the ceiling of my bedroom, the sort of stucco texture. They're thinking, what am I doing sleeping? It's all ending. I thought, I remembered my dad's, I thought 24 weeks. So when I get stressed, I do arithmetic. It's the last thing I was really good at, right? So let's see, this was June 25th was what 24 weeks would be. And I thought, what's the weather going to look like the last time I look out a window? Is it going to be June 20? Is it going to be September? Will I see fall leaves changing color? Dad's funeral had been 18 months earlier. I thought, what's Mom going to look like when she buries me? And this was real. I'm not being maudlin. This is what I was thinking. And the hardest thing was to sit down with my daughter, who was just getting out of college, and her boyfriend, and say, this doesn't look good. But we said, just don't be rash, don't be impulsive, don't run off and get married just so you can do it while Dad's still alive. We're going to deal with this. So then, after the shock, and I was in shock for a bit, then, all right, what are my options? I know there are always outliers. Even if it's 0.1%, I'll go for it. Some people just want to say, I'm done. That's fine with me. I know people who have made that choice. Well, I chose to get engaged, get it in gear, do everything I could. Amazingly, as soon as the biopsy was confirmed, my doctor sent me to the internet. Danny Sanz knew Gilles Friedman, who had that network of cancer patient listservs, and he knew that this community was good people. ACOR has now become smartpatients.com. And I want you to consider what happened in the first 2 hours. Now, you know how long it takes to get a doctor's appointment and how long you have there. The conversation, I'm sure many of you belong to various online support communities for one technical issue or another. Within 2 hours of my posting my first message there, ACOR patients told me, this is an uncommon disease. Find a hospital that does a lot of cases. There's no cure, but high-dose interleukin-2 sometimes works. When it does, about half the time it's permanent. It usually doesn't, they said. But the side effects are severe. They sometimes kill patients. That's why you have to get to a specialist hospital. Don't let them give you anything else first, because our experience as a patient community is that you're less likely to respond if you get something else first. And here are 4 doctors in the Boston area who do it, and their phone numbers. Now, ladies and gentlemen, I assert that this is useful information in the context of the patient's need. Here we are 8 years later, none of this exists in the peer-reviewed literature. What's going on here? Okay, because we are all taught to value the peer-reviewed literature. What they gave me was, number one, information from people like me, so I knew I could trust their perspective, people who see the problems the way I do. There are all kinds of discussions about how do you cope with this feeling, how do you cope with this side effect, and so on. Practical information about side effects. Well, to make a long story short, and I journaled the whole thing, there's this great website called Caring Bridge. Today, a lot of people do it on Facebook, but I really prefer Caring Bridge. It's like a private blog, except it's de-geeked, so pretty much anybody can use it. And it was phenomenal, you know, because aside from just, one of the things you face is the communication burden. You know, at the time, I had 5 siblings in addition to my mom. couple of brothers have since died. But that there was them, there were friends, people who wanted to know, like, what's the update? What's the update? Well, to make that not require individual phone calls and to have it be asynchronous, right? I can write at 2 in the morning if I want, and they'll get a notification email. The next day I'll come, but this is one of the ways that the infrastructure of the internet has altered the experience of being a patient. To wake up when you're wondering if you're going to survive, and to wake up and discover that 20 people left notes overnight, notes of support. Plus, my support went viral because people started forwarding the notification emails. I started hearing from people I'd worked with 20 years earlier. Then I heard from people I had gone to college with, and then kids I hadn't seen since high school. And when you're wondering if the universe is done with you, and people start coming out of the woodwork and cheering, I mean, I don't know how you do a double-blind, peer-reviewed study of that, but I'm here to tell you it's amazing and not bad for free, you know? Well, long story short for me, my treatment started so I was diagnosed in January, the kidney came out the first week of March, the interleukin treatment started in April and ended on July 23rd. I haven't had a drop of anything since. 6.5 months after the diagnosis, my treatment ended. And it's an immune system treatment. It's systemic. Either it works throughout the whole body or it doesn't. So there's that same tumor 50 weeks later. And you know, the punchline is that they had told me that I had to eat, had to pig out because I was losing weight, which is not good. And a year later, my doctor wrote to me and said, "You have not expired, but your order to eat more has." So, and I wrote back to him and said, "Now, about this shoulder, right? Important cultural change item here, okay? 2 years ago, the BMJ, British Medical Journal, invited me to submit an essay to them, one of the top medical journals in the world, about this. They had decided that the time had come to tell the world about this stuff. Now, I could have just said, here's my happy patient story. But as a culture change agent, I was conscious of who's going to be reading this and what are they going to hear. So I asked my oncologist, what would you tell them? Because he has said that he wished he could bottle what I did and have other patients do it. And here's what he said for publication in the BMJ. You were really sick. I don't know if you could have tolerated enough medicine if you hadn't been so well prepared. Now, what's he talking about there? Imagine yourself probably dying. There's one treatment that has a less than 25% chance of saving your life, and it might kill you. 4% of patients die of the side effects. What a lot of people will do is figure, all right, I hope I'm one of the lucky ones. I wanted to know, how do I prepare? What do I need to expect, and so on. So first thing I did was look at PubMed, look at the medical literature. Nothing on interleukin side effects. I asked my oncology team at the hospital. They had no advice. Now they do. They have a pamphlet on coping with side effects. But then I turned to my patient community and I got 17 firsthand stories of how they had dealt with it. Now, this is not the kind of robust, verifiable information you would use to engineer a space probe, but it was a damn lot better than nothing. And my oncologist today says he doesn't know if I could have tolerated enough medicine. If I had to, at one point, my blood pressure dropped to 50/30, and they discontinued the treatment. That's how bad it gets. Capillary leak syndrome. The walls of the capillaries open up, all the fluid runs out, my legs were water balloon, my blood pressure crashed, they stopped the treatment, but I had had enough, and I'm alive. So here's a question for the scientific mind, and this is actually the paradigm-popping question. How can it be that the most useful information can exist outside of traditional channels? How is this? We are taught to look at the peer-reviewed literature. Well, for several years, I used this slide as a kind of generic, this is how networks work. All right, there are connections all over the place. But then I realized there's actually a valid metaphor here. Information in medicine, in a medical episode, is like a nutrient. It enables a more robust response where it's present, right? So here, wherever. And these ungoverned social media connections are exactly analogous to capillaries. They are the pathway through which information nutrients can reach an unexpected place. And it turns out that this is robust. You can test this metaphor in different ways. In fact, in 2011, I gave a TED talk at a university in the Netherlands, in Nijmegen on the German border. And the guy who was this amazing visionary guy named Lucien Englund, both of whose parents died of cancer, and he's committed what's left of his life to transforming healthcare. He and a consultant in 2010 put together this diagram, which is phenomenal. The BMJ printed an animated version of this in February this year. In the old days, all knowledge and skills and assets and everything lived in the institution. And there was this sort of membrane, and things traveled in one direction to the humble supplicant, the individual with the need. Now some people say this is a horrible conspiracy by nasty doctors. I don't know, it's not, I wasn't there. All I know is this is the way it worked. Today, it's more like 2.0. You may remember that when the web first came along, it was Web 1.0, it was read-only, exactly analogous to this. This was read-only healthcare. Today, it's more like this, where we can contribute things. Note, this doesn't mean I'm an oncologist, but it does mean I can bring things to the transaction. And the world that they were predicting 5 years ago is where we're all swimming in a common pond of information. Now, we now understand that what's happening here is not that this person is fundamentally better, but that they have these capillaries. And where they have a need and they apply suction, some pull, to pull things to them, that's what enriches the transaction. It enriches what's possible. All right? So when people say, stop Googling, I think that's not a good thing. And in fact, as I'm sure you know, it's all a network of networks now. And in information theory, medicine has transformed from being a closed system to being an open network. Now, what you'll find is there are a lot of people who develop policy or products or thinking or business practices thinking this way, not knowing that that's happening. New methods, new practices, new consulting, and so on that recognizes this is happening are far better. This is no insult to physicians. The most difficult talk I've ever given was in Jerusalem in April of 2011, a week after my TED talk. If you have ever known any Israeli intellectuals, there is a certain sense of, it's important to know better, or to be as sharp as you can. This was a meeting of the Israel Internet Society, Israeli doctors and lawyers arguing about the ethics of using the internet in medicine when the information there is not well controlled. And they were talking about companies like Patients Like Me, I'm sure most of you know them, in Cambridge, and all kinds of things. I said, it may feel like the world that you were trained in has ended. It hasn't. It's changing. But did you know in 2013, it's the last year I have numbers for, there were 2,200 medical journal articles published every day? Nobody can possibly keep up with them. My oncologist verified it. He said, unless you're a sub-specialist like I am, like he is, you can't. And I said, it's no insult if a less trained person has seen something that you haven't. All right, but there still is no substitute for the trained mind to evaluate it, put it into context, determine its suitability. It simply alters what patients and families can bring to the table. And in fact, the Institute of Medicine, recently renamed the National Academy of Medicine, in 2012, here's where we're starting to accumulate evidence that the establishment is noticing, even though practitioners on the front line generally don't know it. They published this report, Best Care at Lower Cost, and they said that we need a learning healthcare system, and there were 4 cornerstones, and here's one of them: patient-clinician partnerships. Engaged, empowered patients. I wrote an email to Harvey Feinberg, who's the president of the IOM at the time, and said, couldn't you have just said e-patients? It would have made my life easier. But look what they said. Anchored, the system needs to be anchored on patient needs and perspectives. To this day, you will rarely hear people, but it's starting to happen, you'll rarely hear people asking, well, what do the patients think about this problem in medicine? And promotes the inclusion of patients, families, and other caregivers as vital members. So if you are with a relative in the hospital and they are not engaging you, working with you. They are out of fashion. And yet some people don't get it. I am not making this up. Last year, the Belgian government spent taxpayer money to buy a Google ad campaign called Don't Google It. So if you Google a symptom in Belgium, like runny nose or something like that, the top search result that pops up says, don't Google it. And it links to a professionally produced ad agency video where a worried guy is saying, 2 hours ago, I just had an itchy eye, but now I know I have this horrible disease. I'm dying. It's just incredibly insulting. And yeah, and sometimes it's fatal. There's a thing that went around Facebook earlier this month about a 19-year-old who a few years ago was diagnosed with an uncommon form of liver cancer. They beat it, and a year or two later, she started not feeling well again. She went back to the doctors, and they said, don't worry, it doesn't come back. She went home, and she and her mother Googled and found stuff that said it does come back. And they brought this to the doctors, and the doctors said, stop Googling. And she died. And that was 2 years ago. And it was the thing that was in the news was that the doctors have apologized for their role in her death. And the thing is, I'm sure there may have been a trace of arrogance, but it's not a matter of malice. It's a matter of when you're trained with one way of viewing the world, and that changes so that the view you were trained in is no longer current, you can't possibly make the best of every opportunity. And my work now is to help spread the word about this. Some people do get it. Check this. Remember the BMJ? Last June, they published this. They have been on their own patient journey. Look what they said. They created a patient advisory panel. I now sit on a panel of patients with no medical training who advise the editors of the BMJ. They now are having patients do peer review of research papers in their disease. So the BMJ is actually doing the patient needs and perspectives. So for instance, there's a rheumatoid arthritis patient named Kelly Young who is phenomenally knowledgeable about her disease and will point out things that the researchers didn't take into account. And now everybody knows if you're a scientist, you want to get published in a high-impact journal. Well, when authors go to upload a paper, they have to answer, how did you involve patients in defining the question? Whoa. It's not, and in defining the outcome measures. So the culture is beginning to shift. One more example along these lines. This is a woman named Bettina Rink. She is a German doctor who's currently practicing in Sweden, a German researcher rather. Her husband died of malignant melanoma a few years ago, and she watched the whole process of his death and researching all kinds of experiments in process. This is the general process of a clinical trial. You define the question, you design the trial, then you go get some patients, try to get them on board, right? And then you manage the trial itself. What she observed is that patient involvement increases as you get down the road. Like, well, what could they have to contribute at the science end of the journey? And what she says, this amounts to patients doing things right, as opposed to the impact on patients of what question gets studied and how the trial is designed is much higher. So we're discovering there's this really interesting thing happening. When scientists get sick, right, they can experience the scientific process in a new and different way. This is patients doing the right thing. And I want to just quickly mention that a few years ago, 2010, 2011, I think, my dorm buddy Doug and I, a friend of ours named Janet Freeman Daly, who's a PhD, Caltech was where she got her doctorate, right? So she lives in Seattle. She worked for, was it Boeing, I think, or somebody for a long time. Anyway, she found out she had non-smoker's lung cancer. Things were not going well. And he told her about my case. She read my book that I'd published out of my cancer diary, and then we connected. She said, where can I find a good patient community? And The one that I was in didn't have good people, but there's another company, it's Boston-based, named Inspire.com. They have a great lung cancer community. And within a year, she had learned about a newly discovered mutation. Now, she's not at a schlock hospital. She's at Virginia Mason Medical Center in Seattle, which is top-notch. But a newly discovered mutation, and that there was a clinical trial going on. And long story short, she had her specimens retested, and within a year, she was what we call NED, no evidence of disease. Her doctors at Virginia Mason welcomed this. They didn't say, stop talking to patients on the internet, okay? This is what's newly possible. It is no indictment of doctors anywhere if they don't know everything. Well, so now this starts to look different, because there are people who have the idea that medicine is all about the doctors, the scientists, and so on. Anybody know Thomas Kuhn's name? A few people. Well, in 1957, he was at Harvard, and he wrote this in-depth analysis of the Copernican revolution. And in 1962, he had looked at other revolutions, and he published this epic book, The Structure of Scientific Revolutions. This is the book that made the word paradigm popular in the US. He rapidly, within a few years, said, "Oi!" This word got out of control because it just became the cheesy buzzword. If you're interested in rigor, read this book carefully, because what he's talking about, in human cognition, there is this cloud of things, and what the mind does is like looking at clouds in the sky. It says, oh, look, there's a puppy dog, there's a bunny rabbit. Well, we develop concepts that are distillations of the raw cognition, and we build theories about how the world works. And he identified, this is from the introduction to the second edition, he thought not only that there are scientific revolutions, but that they have a structure. All right, and I'm asserting that the time is coming for us to rethink what the object patient can be in medicine. And see, he insisted, Wikipedia says, that a paradigm shift was a melange of sociology, enthusiasm, and scientific process, not a logically determinate procedure, caused an uproar. Whole bunch of scientists saying, hey, what do you mean? I'm rational. Well, indeed, there's the rational part, but I'm sure you know there are things that have come along that took forever for people. A man named Ignaz Semmelweis identified that washing hands between mothers in the maternity ward reduced maternal deaths by 10 times. And he was locked up and died in an asylum in his 40s. Because medicine at that time didn't yet understand that bacteria exist. So to them, this was like witchcraft. Hey, look, I washed my hands, no more dead babies. Well, this is serious stuff. Anyway, the scientific field goes through. Normal science is puzzle solving. Everybody agrees what the fundamental concepts are, and we solve things. And that's because then we develop a paradigm. Before Newton, I was amazed reading this book. I didn't realize that back in the days of Aristotle, the way they explained the motion of a pendulum and the behavior of objects in collision was they said that the rock is changing its nature from being a slow-moving rock to a fast-moving rock. That was the paradigm. Newton came along and said, dude, the rock is the rock. It keeps doing what it does until something acts on it. That was a wholesale paradigm change. But then, see, a paradigm lets you predict what would be a reasonable outcome from an experiment. But every now and then you do an experiment and it goes clunk. And he said those are anomalies. And when you start having a whole bunch of clunk, 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 there is trouble in the field. This is what happened in physics in the late 1800s when quantum mechanics came along. The book includes some amazing essays of super sharp physicists writing letters to each other saying, I'm losing my mind. Well, anyway, that produces a crisis which leads to revolution. And let's see, I want to jump ahead, so I'm going to skip through a few of these things. The state of patient engagement today is that it's a puzzle with no agreed paradigm. He said that when a field is pre-paradigm, what you find is people with studying different parts of the elephant and having no way to talk to each other, conflicting or just plain different tangent models. Today, what we have with patients, a great example, he cites electricity before Franklin. Some people were fascinated with how it flows, so they thought it was a fluid and they'd be able to put it in bottles and sell it. Others were fascinated with the attractive and repulsive forces that Franklin called positive and negative charges. Once it all got rationalized, they could all talk together, they could hold conferences and so on. Well, in medicine today, we have many different frameworks of what patient engagement is. Center for Advancing Health has this excellent engagement behavior framework. Meanwhile, there's this thing called the patient activation measure that documents when patients do certain things, they get better outcomes. Meanwhile, there's the National eHealth Collaborative that has a patient engagement framework that has almost no overlap with the others. We even have many conceptions of what the nature of a patient is. And if you ever watched a field where you work evolve, this is fascinating because you can see that it just needs to get its act together. A lot of people ask if the patient is compliant, if the patient follows instructions. Other people have been writing for years about the autonomous patient, people who make up their own mind about what's important and what they want to pursue. Then there's the collaborative model, Society for Participatory Medicine. And believe it or not, in JAMA, the Journal of the American Medical Association, a few years ago, we even had the proposal, are patients knights, knaves, or pawns? What? What are we talking about? Well, the result is we have inconsistent standards of practice. And when it comes down to things like healthcare innovation, CMS attempting to improve healthcare or health policy on electronic medical records, we have a lack of policy support because if the paradigm says it's hard to be a doctor, so what good could patients do with any of this information, then there's no reason for federal policy that says give us our data. And I mean you and your family's data. Well, and so I'm asserting that anyway, I'm going to jump ahead. I just want to say that 3 weeks ago yesterday, my wife, shown here, had both her knees replaced, and here she is walking around without a cane. She got a phenomenal new method that is performed by a doctor in Westchester County, more than 3 hours away, who I met some years ago through social media. And thanks to single-payer Medicare, we were able to go there. He's not out of network. This is a modern guy. He has an incredible website, Howard Lux, L-U-K-S is his name. He records YouTubes. He has a flat panel display on the wall of every exam room, so while he's doing something on the computer, you can see what he's doing. He'll call up the images and come over and talk and point things out. And yet, when we were transferred from the hospital to rehab after her surgery, piles of paper, because we don't have electronic data exchange in most of medicine these days. The impact of this can be serious, and I mean you really, really, really want to get all up in their face about this. When my mother had a hip replacement a few years ago, she was transferred to rehab. They didn't have electronic data exchange, most people don't, and her thyroid condition got copied over backwards, hype-er, and it came over as hype-o. The thing is, this is not just a patient rights thing. The best doctor in the world could have killed her, right? People perform better when they're informed better, and data quality is important. What saved the day? There's a dynamic I've heard about all around the world that I call the alpha daughter in many families. The woman who walks in is on top of things. Well, my two sisters were there, and they said, could we check the chart? And happily, the rehab place said, sure. They found the mistake, and it got fixed before there was any harm. So there you have it, patient and family engagement, improving the quality of data, improving outcomes, avoiding disaster at no cost to anyone. So here I was on the night of the physical. This is a guy who was dying of stage 4 cancer and didn't know it. 10 months later at the office Halloween party, by this time the company had moved to Crosby Road here. There I was grinning at the ghoul. I'm glad somebody took this picture because that's pretty much how I felt. My treatment had been over for 3 months. I'd pictured my mother's face at my funeral, but instead, in 2009, we got to laugh together on the day when I did get to walk my daughter down the aisle. And I'll tell you, every time I see my granddaughter now, I'm just really glad to be alive. You know, none of this is anti-medicine. All of this is about modernizing how we think about the flow of information. Because when that works well, the best is possible, and when it doesn't, it's not. Thank you for your attention. I look forward to